Hello, my name is Rebecca Cavazos. I'm a neonatology attending and a member of the NIPPV team, and today I'm going to be giving this presentation on nasal intermittent positive pressure ventilation, also known as NIPPV, and how we will be using it in the NICU. In this presentation, we will be going over the user's guide to NIPPV and discussing when to use it, how to start it, and how to adjust it. Next, we will go over how to enter the orders and how to document NIPPV and its settings for your patients. At the end, we will go over frequently asked questions and comments from care providers about NIPPV. The NIPPV team, or the Avoiding Lung Injury team, is a multidisciplinary team in the NICU that's focused on preventing lung injury and decreasing the rate of BPD in our unit. The biggest contributing factor for BPD is how much time a patient spends on the ventilator. Reducing time on mechanical ventilation leads to reducing lung injury, which means less BPD. Currently, we only have two options for non-invasive support, CPAP and high-flow nasal cannula. But now we're introducing a third non-invasive option, NIPPV. What is NIPPV? NIPPV stands for Nasal Intermittent Positive Pressure Ventilation. It's a mode on a mechanical ventilator that provides a steady PEEP through a nasal interface, much like our bubble CPAP does. In NIPPV mode, however, the ventilator is able to provide a set number of breaths per minute at a set pressure above the PEEP, providing intermittent breaths to the patient through the nasal interface. What are the benefits of NIPPV? Multiple randomized controlled trials and a Cochrane meta-analysis have shown that in patients who were placed on NIPPV instead of CPAP, there was a decrease in the need for intubation and mechanical ventilation, a decrease in extubation failure up to 7 days post-extubation, and a decrease in the total number of mechanical ventilation days. Some studies showed an improvement in BPD rates, while others showed no difference. But no study showed an increase in adverse outcomes, such as necrotizing enterocolitis, spontaneous intestinal perforation, pneumothorax, intraventricular hemorrhage, or retinopathy of prematurity. The following is the user's guide for NIPPV. Who will be considered for NIPPV? Our target population will be premature neonates born at a gestational age of less than or equal to 32 weeks, or with a birth weight of less than or equal to 1,500 grams, and who require positive pressure ventilation for respiratory failure or apnea. NIPPV can be used in two ways, as primary or secondary respiratory support. In the primary mode, NIPPV will be used as initial or pre-intubation support. These will be babies who did not need to be intubated in the delivery room, or who were briefly intubated only for surfactant administration and quickly extubated. When used as secondary mode, NIPPV will be the post-extubation respiratory support. This will be for the babies who were intubated for respiratory failure or apnea and who are now being extubated to non-invasive support. When initiating NIPPV, your starting settings will differ based on whether you are using NIPPV as a primary or secondary mode of respiratory support. In the primary mode, your PIP will be somewhere between 20 and 25. Your PEEP will be between 5 or 6, and your rate will be somewhere between 20 and 30. Due to the non-invasive delivery of pressures, your I time will always be 0.5. Your FiO2 will be adjusted to maintain your targeted goal oxygen saturations. When you're extubating to NIPPV, your starting settings will be slightly different. Your PIP will be 2 above your PIP reached on your ventilator. Your PEEP will be the same as it was on the ventilator. Your suggested starting rate will be 20, and again your I time will be 0.5. Your FiO2 will be adjusted to maintain oxygen saturation targets. The NIPPV interface algorithm is very similar to the bubble CPAP interface algorithm. Once it has been decided that a patient will be placed on NIPPV, the supply should be gathered and assembled, using the mask as the initial nasal interface. If there is an adequate seal, the patient should be maintained on nasal mask, monitoring every 3 to 4 hours for signs of pressure injury. If there is a pressure injury that requires an interface change, the mask should be switched to nasal prongs, and the site should be reassessed every 24 hours to see if skin injury has improved. If so, the patient should be switched back to mask. If, after placing the patient on NIPPV, there is not an adequate seal, which is not addressed by repositioning and equipment check, then the care team may discuss with the provider if a trial of nasal prongs may be beneficial. Maintaining a patient on NIPPV is similar to maintaining a patient on bubble CPAP with some slight differences. In maintaining a patient on NIPPV, one must always ensure that a properly functioning OG tube is in place in order to appropriately vent the stomach. With regard to settings, unlike conventional ventilation, NIPPV will not significantly support minute ventilation. It will help increase the mean airway pressure in infants with apnea or periodic breathing. The PIP can be increased by 1 to 2 centimeters of water up to about a max of 26. The PIP should not be increased above 26, as this can contribute to leak and gastric insufflation. Rate can be increased, but using a rate higher than 30 will result in an inability to reach the set PIP because the I time is already at 0.5. If the FiO2 is high, you can consider increasing PEEP by increments of 1 up to a max PEEP of 8 in order to optimize mean airway pressure. Blood gases should be continued while a patient is maintained on NIPPV. The care team can consider daily blood gases for about 2 to 3 days after starting NIPPV. When weaning NIPPV, the team should attempt to wean either the PIP or the rate once per day. NIPPV breaths are unsynchronized, so it can be uncomfortable for long-term use, and it's recommended that NIPPV be used for only about a 7 to 14 day period. When weaning, the team can attempt to wean the PIP by 2 or the rate by 5 daily, based on the blood gases. Patients may also be weaned clinically based on FiO2 and the frequency of apneas. The patient can be safely transitioned to bubble CPAP once the PIP is about 16 to 18, the rate is 10 to 15, and the PEEP is less than 7. Indications for intubation or reintubation are the same as the indications for intubation in a patient on CPAP. The team should consider intubating a patient with moderate to severe increased work of breathing, frequent apnea, bradycardic, or desaturation events, for example, more than about 3 per hour, or if the patient has events requiring bagging. The team can also consider reintubation if the patient has a pH persistently less than 7.25 and a PCO2 over 65. Providers can refer to this flow sheet when admitting a VLBW patient with RDS and respiratory failure. A VLBW patient can be admitted and, at the provider's discretion, placed straight on bubble CPAP. If a patient does not require intubation, the care team can also decide to place the patient on NIPPV. If the FiO2 is greater than 60%, the team can consider performing the Ensure technique and extubating to NIPPV. If the FiO2 is less than 60%, the baby can be placed initially on NIPPV and the settings weaned as able, transitioning to bubble CPAP or nasal cannula when minimum settings are achieved. If a patient requires intubation and mechanical ventilation in the delivery room or shortly after, once the patient meets extubation criteria, they may be extubated to NIPPV and weaned as previously discussed. If the care team wishes, however, patients may be extubated straight to CPAP or even room air as clinical status permits. Providers can remember some key points when starting and maintaining a patient on NIPPV. First, it's very important to ensure that the patient has adequate gastric venting. Providers can consider placing a larger-sized OG tube to better vent the stomach. Providers can even consider venting the OG tube more frequently to aid in minimizing stomach distension. Secondly, it's important to remember that the breaths in NIPPV are not synchronized. It's best to try and pick a rate that is a factor of the patient's native respiratory rate. Providers can monitor the patient's work of breathing and adjust the rate as needed. And again, NIPPV is not meant to be a long-term therapy. Our goal is to limit its use to 7 to 14 days before weaning to CPAP if possible. Shown here is an aid to help demonstrate and explain how providers can best synchronize NIPPV breaths to patient breaths. In the first example, you can see the baby's respiratory rate is 40 and the ventilator rate is 20. Every other breath the baby takes is assisted by the ventilator breath. In the example below this, the baby's respiratory rate is 20, but the NIPPV rate is 15. The NIPPV rate is not synchronized to the baby's respiratory rate, so the NIPPV is not adequately supporting the baby's breaths. The following will be an EPIC demonstration. We will go over order entry in the EPIC system, as well as documentation for nursing staff and respiratory therapists. It's important to note that when physicians bill for patients on NIPPV, they will be considered critical care. When ordering NIPPV, in the Orders section, type in non-invasive. When a provider searches for non-invasive in the Order section, these are the results which will appear. At the bottom you can see there are two choices: ventilator non-invasive pressure and ventilator non-invasive volume. For our purposes, we will be selecting ventilator non-invasive pressure, as we will be setting PIPs and PEEPs and not tidal volumes. Here is the empty order entry that you will see pop up when you select ventilator non-invasive pressure. Under Mode, you should select NIV, which is non-invasive ventilation. The provider should then proceed to fill in the rest of the desired settings. Remember, the NIPPV system does not have a flow sensor, so there will be no pressure support. Shown here is a sample of flow sheet documentation in the respiratory flow sheet. You can see that under ventilator type, the baby log ventilator should be selected. The mode should be NIV for non-invasive ventilation. The remainder of the settings may be filled in as required. When setting up the NIPPV system, RTs and RNs should work together to assemble the circuit and place the baby on NIPPV. For troubleshooting and questions, QR codes are available at the bedside and in the break rooms for just-in-time learning and support. Additionally, super users, listed below, are available for at-the-elbow support. Below are some questions and concerns that have been brought up by bedside staff. Does a patient on NIPPV get one-to-one nursing in the first week of life, similar to ELBW patients in the pavilion on CPAP? Not currently, but we are working to get the nursing staffing model like CPAP. If a patient is on the ventilator for NIPPV and we need to transition to CPAP, can we just go to ventilator CPAP instead of bubble CPAP? In general, our goal is to continue to use bubble CPAP and not to default to ventilator CPAP. If alarms are going off frequently, indicating a leak on the ventilator, what do I do? First, the bedside provider can evaluate the infant to make sure that the interface is correctly positioned. Secondly, the bedside provider and the RT can discuss other troubleshooting options, like a chin strap or a position change, to minimize the leak. If a patient is failing CPAP, should I go ahead and set up for NIPPV? Not necessarily. It's unclear if using NIPPV in patients who are failing CPAP is beneficial. It's okay to try based on the clinical scenario, but it requires discussion between providers taking care of the baby. How do we know if introducing NIPPV into our unit helps our patients? What if it harms them? This implementation of NIPPV is being done as a QI project. The ALI team will be closely monitoring to see how many patients are treated with this modality, the indications for which they were placed on it, any complications that arise, and we'll also be following our successes and failures. We'll also be making revisions to the guidelines based on what's working well and what's not working well in our unit. What's the most important thing a nurse can do in providing for a patient on NIPPV? The number one thing a bedside nurse can do to ensure success on NIPPV is to make sure that there is adequate gastric decompression or venting of the NG or OG tube. Shown here are QR codes for instructional videos on NIPPV. The first QR code is to a YouTube video that explains what NIPPV is. The second QR code goes over circuit calibration. The third QR code demonstrates the process of extubating an infant to NIPPV. The fourth QR code regards nursing troubleshooting, and the last QR code goes over respiratory therapist troubleshooting.